Okay, this is going to be the last video of a series, 6-part series now on pharmacokinetics. I'm going to do one more video covering the basics of pharmacodynamics. This is going to be altogether a 7-part video on pharmacology. Just to get, and it's made basically for medical students to get all of the pharmacokinetics that are important for the USMLE Step 1 board exam, and also just to get the basic rough edge foundation that everyone should have for pharmacology if it's a part of your profession. So I'm talking about impaired renal clearance. You got to understand also that some of this pertains to impaired hepatic clearance. If you have hepatic failure and a drug is eliminated via hepatic metabolism, then you're going to have to decrease your dose in order to not have, and you're going to have to decrease the dose in order to not have an increased concentration at steady state. And same thing for renal. If something is excreted renally and you have renal failure, let's suppose that you have a drug that is only filtered, it's not secreted, not reabsorbed by the kidney, it's only filtered, then your clearance of that drug is going to always equal the GFR. And so let's say your GFR drops from 120, it goes down to 60. If it did that, then the output, the elimination of that drug is going to be cut in half, and so then your dosing has to be cut in half in order to not reach toxic levels. If you want to stay in that therapeutic level, you need to cut your dose in half. And so that's what we're going to talk about: renal injury and drug dosing. So there's 3 considerations. Does a drug cause renal toxicity? So some drugs are not eliminated by the kidney, but they can hurt the kidney. And so if a drug causes renal toxicity and you have renal damage, you want to consult maybe a pharmacologist or consider changing the drug to something else. Does it accumulate? If renal failure occurs, will the drug accumulate? Will it go into higher levels? And if it accumulates, will it have extra renal toxicity due to the accumulation? And then the last thing you need to think about is if somebody goes onto dialysis. Dialysis meaning renal replacement therapy. It's called dialysis. If you go into renal replacement therapy, how do you alter the dosing in that situation? So drugs can either be cleared completely by the liver, completely by the kidney, or together by the liver and the kidney working together. And so, if something is cleared by the kidney at all, by the kidney alone or by the kidney and the liver, if there is kidney injury, you're going to have accumulation of that drug or its metabolites. And if increased concentrations moves you out of the therapeutic window, then you need to decrease your dosing. Now, I found a research study that showed the most commonly used, overlooked, for toxic medications. Those include aminoglycosides, amphotericin, phosphate-based enemas, radiocontrast, and hydroxyethyl starches. Just a reference for your future practice. So I've hammered this over and over again. At steady state concentration, the intake, the input, is going to equal the, not necessarily the clearance, but the elimination. I've put clearance in here as a surrogate. Why? Because we can talk about the clearance as what's actually going to change when the renal function is impaired. It's the clearance that is going to be altered. And so as the clearance is altered, you're going to be still taking in more and more of the medication until it gets to a high enough concentration that the clearance is going to equal. So you're going to, let's say you're taking 10 milligrams of a drug. I'm taking 10 here. I've got a current a current steady state of this much right here. Just going to outline it. But every time I take in this much and put it in here, this other one comes out. That's when input equals clearance. Now, if my clearance is diminished, then I will get another one added, and another one added, and another one added. It's going to keep, and so in that time I might have one leave, and then I have another one added, and another one added, and that time I might have another one leave, and I have another one added, and then at that point, my inputs are going to equal my outputs. Eventually, I will come to a concentration that is so high that is so high, even if my clearance is this little tiny bit right here. So my clearance, let's say my clearance used to be this whole volume, and then my clearance is down to this much. If the concentration down here is really high, then if I only take out that much, it's going to equal whatever might be coming in that same time. So as the concentration goes up, the removal of the drug will increase even though the clearance has decreased, and eventually it will come to another steady state. But that steady state concentration will be much, much higher than what it was. And so you know that my steady state concentration, input equals elimination, steady state concentration, my input here, my elimination here. And I can solve for the concentration steady state, and I can say, what are the factors that affect steady state? These are the factors that I can control. I can control my dosing rate, and I can control my dose. I cannot control anything else. I can make some simplification, some assumptions. I can say, well, the clearance has decreased somewhat, but now it is at a new steady state. I don't know that's for sure, but we'll talk about what happens if that's not true here in a second. I also cannot change my bioavailable fraction. You know that the concentration is mass, the mass over the volume, and we're talking about the volume of distribution. Well, that volume of distribution actually changes when you have renal failure, so you're retaining fluid, and so you're going to have more volume inside you, so your volume of distribution actually changes. We make a simplifying assumptions that all of that stuff doesn't change. But in fact it does. These are all factors that affect steady state. But the only factors we can control are the dose and the dosing interval. And so the clearance is something that changes, but that's altered by the renal failure itself. It can also be increased by renal replacement therapy. So I've talked about, basically, I've already pointed out what can I change. I can change my dose, I can decrease the dose, or I can increase the dosing interval, or I can do both. This chart is adapted from Goldman Cecil's Internal Medicine, and so we've got the drug in this column, and we've got the type of elimination, so if it's renal, hepatic, and renal, and then we have the normal half-life of the drug, and then what the half-life is at end-stage renal disease. Now you remember that half-life, the T 1/2, is equal to 0.693 over K, where K is going to be, we can replace this with times volume of distribution over the clearance. What I'm trying to show here is that we can actually use these new half-lives, for example, to calculate this K, or this reaction, this rate constant. And by calculating that rate constant, if we make the assumption that the volume of distribution didn't change, which we know that's false already, but it's a close approximation to truth. If we make the assumption that the volume of distribution didn't change, we can actually calculate what the new clearance is. But this already gives us the method desired for each drug. So this gives us recommendations. What do the pharmacologists say to do? If we're giving amikacin, for example, how do we change it? Well, we're going to decrease the dose and increase the dosing interval. For aspirin, we're just going to increase the dosing interval. For carbamazepine, we're going to increase or decrease the dose. And at a GFR of 50%, or from 10, not of 50%, but of 50 mils per minute, a GFR of 10 to 50, or a GFR of less than 10, this is how you adjust the dose. You give 60 to 90% of the original, or you give all the way down to 20% of the original dose. This is going to take into account a couple of things. It's going to take into account what amount is filtered. It's going to take into account what amount is secreted. It's going to take into account what amount is reabsorbed, and it does all of that for each of these different GFRs. Then in the last column here, we have whether or not it is removed by dialysis. So some drugs are removed by dialysis, other drugs are not. So that means if somebody's on renal replacement therapy, if the drug is removed by dialysis, we need to know what to do in that situation. If it's not removed by dialysis, we also need to know to basically not to give an extra dose. Now, simplifying equation is that the dose you give during renal failure is equal to the normal dose of the drug divided by the ratio of the clearances. This assumes that you know the normal dose of the drug and you know both the normal and the impaired clearance. But if I know the normal dose of the drug and I know the normal clearance, then I can actually calculate what was the concentration steady state. I can also from that calculate what the volume of distribution is. And so then I can use all of that information to go in and I can just reuse this as my new dose, my new clearance, and assume the old volume of distribution is the same. Assume I want the same concentration steady state. I can just recalculate the whole thing. So you don't really have to remember that the new dose is a ratio of the original dose, is equal to the original dose times the ratio of the clearances, but it kind of makes things faster. Now let's talk about this ratio really quick because it does make things a little bit faster. If a drug is freely filtered, it's not secreted or reabsorbed, then the ratio of these clearances is equal to the ratio of GFR during renal impairment to the normal GFR. This is usually not going to be the case, that it's not freely filtered and not secreted or reabsorbed. So what can we do if we don't know the clearance? Well, we have the half-life already. We saw that we have a chart of how the half-life has changed in all of those situations. And so if we were to take t of 1/2, let's start right here. The t of 1/2, the half-life is equal to 0.693 times the clearance divided by the volume of distribution. If I were to use this equation and solve for clearance, I would get this right here. So the clearance is equal to 0.693 times the volume of distribution over the half-life. So 0.693 times the volume of distribution, we assume that the volume of distribution is the same, so it's a constant, and so the new clearance is equal to some constant over the half-life. So I can get down to the fact that the clearance, this ratio, clearance during renal failure over normal clearance, is equal to the constant over the half-life, whenever normal half-life of the drug, divided by constant over the half-life during renal insufficiency. Now the constants will end up canceling each other out, and you get the ratio of the half-lives, and you can use that ratio as well. So the dose during renal failure could equal this simplification, or it could equal this simplification. The caveat, I've already said this, the volume of distribution is altered by renal failure, so you got to keep that in mind. Lots of things change during renal failure. Intestinal absorption changes during renal failure. And so you may find out that even though you've increased your dose or you've decreased your dose or whatever you've done to your dose, it doesn't change in the exact same way you imagined it would because you're not absorbing. Your bioavailable fraction has changed. Now, if you've studied renal physiology, you'll know that the creatinine clearance is a good way to estimate GFR. Creatinine clearance is approximately what the GFR is. So let's say, what if the creatinine level is rising? So creatinine level is rising, that means the creatinine clearance is decreasing. It's actively decreasing right now. So you know that when you're estimating GFR, the creatinine clearance is only a good estimate of GFR whenever you're at steady state. If the creatinine level is rising, so let's say that we have some of the creatinine being filtered into the glomerulus, but if you shut down some of that, then your levels will start rising, and they will continue to rise until there is enough, a high enough concentration that this new decreased clearance, down here, that this little amount that's left in filtration will cause the input to equal the output. So the concentration will constantly rise until input equals output. So that means, let's say that my creatinine is rising. Let's say I measured it right here and I calculated what the GFR was. The GFR, let's say at this point, I would have calculated it as 50. But if I would have waited a little bit longer and measured it right here, I would have calculated the GFR as 40. And then the creatinine is still continuing to rise. Once it gets to steady state concentration, I calculate the GFR, and I calculate the GFR as 30. So if the creatinine is actively rising, whatever you calculate, so my calculation initially was 50, whatever you calculate is going to overestimate the actual GFR. The actual GFR was 30. So just remember, creatinine rising leads to overestimating. Rising, overestimating. That means your clearance will be overestimated, so you need to reduce your calculated dose by whatever makes you feel good, because there is no magic equation for this. On the other hand, if the creatinine is decreasing, that means that you have a certain amount input, but your output you're taking away faster than it can be brought in, so it's actively decreasing. Once you get to that new steady state, you can calculate and say the GFR right now is 100, but it was actively decreasing. So if I would have calculated it right here, I would have said that the GFR was 70. If I would have calculated it right here, I would have said it was 60, and initially if I would have calculated it, I would have said it was 50. So if the creatinine is decreasing, my calculation of the GFR is going to be an underestimate of the true GFR. My clearance will be an underestimate of the true clearance, and so I need to increase my dose by whatever makes me feel good, because there is no magical equation for this. Let's suppose that normally you are dosing somebody and you give them that first dose and the second dose and the third dose, and then eventually you reach this concentration steady state right here, and you're happy with that. But let's suppose that they have renal impairment, and because of that you have to decrease their dosing frequency. Keep the dose the same though, so that first dose, second dose, third dose, fourth dose, fifth dose. And so you see that what you have done by increasing the dosing interval, it may take you longer to get to the steady state. We've already said you've altered the clearance, so our half-life of the drug is altered. Everything is altered, so you might have increased the half-life to such a point that it will take you way too long to get to a therapeutic dose if you're starting out on a new drug during renal failure. And so even whenever there isn't a loading dose, you will probably have to have a loading dose with renal failure. But you have to be very careful. The recommendation is, if there's normally a loading dose, fine, do a loading dose like you normally would. If there's not a loading dose, consider doing a loading dose. Especially if somebody has renal or hepatic failure, that means you're going to have to extend the dosing interval. Now let's talk about what happens if we give somebody a drug. Normally if you gave somebody one single dose of a drug and you watch, it would fall over time and approach zero. If a drug is completely renally excreted and you gave them that initial dose, it would not fall down to zero. It would just stay constant. Or if it did fall, it would fall at a very, very, very low, slow rate, and it would not get down to this zero in any time soon. But the second you give that person dialysis is going to suck out everything all at once. And then you get to the end of dialysis. At the end of dialysis, you give your new loading dose. So you give a loading dose. You don't give any maintenance doses unless you need a really tiny maintenance dose. But you give your loading dose. You don't give any maintenance doses. And then you give your next loading dose after the next hemodialysis, if a drug is cleared by dialysis. Each drug and drug manufacturer will give you a protocol for dialysis, but what you need to know is that the dialysis protocols are changing all the time, and so you might not have a drug protocol that matches the dialysis protocol that your patient is on. In that situation, you have to have very, very close monitoring of plasma drug concentrations. So here is the current state of medicine. Administer your medication after dialysis. Alter the dose and dosing interval accordingly. A few high-yield considerations. Dialysis can cause hypotension. So if a person is getting an antihypertensive medicine, give them one that is dialyzable. Don't give them one that is not dialyzable. Why? Because you want the effect of the medicine to drop away as the hypotension due to dialysis is kicking in. This will allow for some sort of, semblance of balance. If you're not 100% proficient with renal failure or dialysis on a specific medication, you need to consult a pharmacist. I found several papers, scientific papers, that have documented the necessity to consult a pharmacist in these situations. And as a medical student, we have to always study and attend these multidisciplinary events, stuff. So it's part of the multidisciplinary stuff. Beware of bad outcomes. I went and found a couple of different case reports. So normal dose of gabapentin was caused encephalopathy in 2 patients on dialysis. There are several case reports like this. Here are a few citations for renal dosing and pharmacology for renal replacement therapy.